Building. A very warm welcome to everyone on our monthly a very warm welcome to everyone in our monthly seminar BLK Leads. Today we have decided to talk on a very interesting and a very common topic, which is UTI. It is something that we all as pediatricians see in our practice. And since the guidelines for UTI were recently updated in 2023, we're going to discuss those in detail. To chair the session with us, we have Dr. Prashant Jain, who's a Senior Director in Pediatric Surgery and Urology at BLK Center for Child Health. We welcome you, sir. And Dr. Vinay and Dr. Vinay Agarwal, who's an Associate Director in Pediatric Nephrology at MAX Smart Super Speciality Hospital, Saket. We welcome you, sir. I request all the delegates, participants to please write down their questions in the chat box, and they will be discussed in seminar. And without much ado, I request Dr. Swati Bhardwaj, who's a consultant in pediatric nephrology at BLK-MAX Hospital, New Delhi, to please start the session and enlighten us. Thank you.
Yeah, a very good afternoon to you all. Thank you, Dr. Ritika, for kind introduction. Yeah. So we know UTI is a very common bacterial infection of childhood, which we deal with in day-to-day clinical practice. And many children go on to have recurrence of UTI, and risk factors for UTI recurrence being reflux and bowel bladder dysfunction. And in light of the new evidence that has emerged over the last decades, the Indian Society of Pediatric Nephrology has updated its guideline. The first guidelines were published in 2001. They were largely a consensus statement based on opinion from the experts. The next set of guidelines were published in 2011, which we were following till date, were quasi-evidence-based, while these updated guidelines have conformed to the international standards, and they have been developed based on good quality evidence. The guideline formulating group consisted of 6 working groups and an evidence review group who formulated questions in the PICO format and conducted systematic reviews and analyzed the evidence. And where good evidence was based, recommendations were provided, and where there was not enough literature, clinical practice points have been provided. This document has been published recently in October 2023 in the Pediatric Nephrology Journal, and it can be accessed freely. And the guideline document consists of 17 recommendations and 18 clinical practice points in the areas of diagnosis and therapy of UTI, imaging after the first episode of UTI, recurrent UTI, bladder bowel dysfunction, and diagnosis and management of vesico-ureteric reflux. So starting with UTI diagnosis, as we all know, infection of the urinary tract is diagnosed based on growth of single uropathogen with significant colony count in the presence of symptoms, and urine culture is the gold standard. So the symptoms and signs of urinary tract infection may often be non-specific in young children. So we have to investigate, and the investigation begins with collection of a urine sample. So the guideline panel suggests using clean catch method for urine collection for toilet-trained children, and also for non-toilet trained stable children, clean catch should be attempted initially, and it may be augmented with the help of quick wee method to induce micturition. If unsuccessful, the urine sample should be collected by catheterization or suprapubic aspiration, while adhesive bags and nappy pads are associated with high contamination rate, and they should not be used for sample collection. And it has been seen that perennial cleaning with soapy water before clean catch sample reduces the contamination rates further, which is comparable to a catheterized sample. While for sick infants, we should not wait for sample collection by clean catch method, and catheterization and suprapubic aspiration should be attempted and promptly antibiotics initiated. So once sample has been collected, we need rapid screening tests which can help us guide the empirical antibiotic therapy, because we know the culture will take 48 hours to come back. So the guideline panel recommends using urine dipstick, leukocyte esterase and nitrite combination as the first line screening test for UTI. The reason being either a positive leukocyte esterase or nitrite has good sensitivity of 84% and good specificity as compared to urine microscopy for leukocyturia. And the assessment, and it is a rapid bedside dipstick test, and trained personnel and infrastructure is not required in some of the areas which may not be available. And if the sample should be processed within 1 hour of voiding or at maximum 4 hours after refrigeration of the sample. And when feasible, urine microscopy in freshly voided sample can be used as an alternative to the dipstick for screening of UTI. But one should exercise caution by interpreting urine dipstick results in young infants. As we know, they void frequently and there may not be enough nitrite concentration in the urine. So the nitrite test might be negative. So in that case, the clinician should use their clinical judgment to decide starting empirical antibiotics. Culture remains the gold standard for diagnosis of UTI, and the UTI is confirmed based on significant growth of single bacterial species on the urine culture in the presence of symptoms. And the cutoffs have been provided for different methods of sample collection. As you know, suprapubic aspiration is associated with least contamination rate. So any growth which is minimum more than 10^3 colony forming units is considered positive, while catheterization will have lesser contamination rate as compared to clean catch specimen, and a cutoff of 10^4 colony forming units has been suggested, which is same as the previous guideline, while the cutoff for growth in clean catch specimen has been lowered from 10 to the power 5 to 10^4 to 5. The reason being the previous threshold of 10^5 was given several decades back, and the new evidence shows that in children younger than 2 years, even in the presence of UTI, they may have a lower colony count. Studies showing simultaneous cultures from suprapubic aspiration and clean catch specimen confirm the similar findings. So this cutoff has been lowered so that we do not miss UTI by using a stringent definition. So in young infant, 10^4 cutoff is acceptable by using a clean catch specimen. Asymptomatic bacteriuria is defined as positive urine culture that is 10^4 to 5 CFU of single pathogen in clean catch specimen, 10^4 CFU in catheterized, and any growth in a suprapubic specimen in the absence of symptoms. And a recent meta-analysis has reported it may be prevalent 0.37% in boys and 0.47% in girls up to 19 years of age, and almost half of them may be associated with leukocyturia as well. And the guideline panel does not recommend use of antibiotics for the treatment of asymptomatic bacteriuria, because this may lead to replacement of this asymptomatic bacteria with more pathogenic and virulent bacteria and may lead to actual UTI. And the guidelines also suggest that routine urine culture should not be performed in asymptomatic children, because many times we get a growth and then we keep on chasing, giving more antibiotics and likewise. But however, if a child is planned for instrumentation or surgery in the presence of asymptomatic bacteriuria, one may consider using antibiotics only in that population. Otherwise, asymptomatic bacteria is not to be treated with antibiotics. To summarize, when a child presents with fever without focus, a young child or an older child with specific urinary symptoms, a clinical diagnosis of UTI should be considered, and a urine culture and dipstick test should be performed. If leukocyte esterase or nitrite are positive, empirical antibiotics can be started and modified according to the culture report. If leukocyte esterase and nitrite are negative and the child does not have any risk factors for UTI, then we can wait for the culture to begin in antibiotics. And if specific risk factors are present, especially in young infants, antibiotics can be started and followed up with the urine culture report. So once we have diagnosed UTI, it is very important to treat it appropriately to eradicate the causative uropathogen and prevent the progression of infection, kidney damage, and its related complication. So the guidelines suggest that antibiotics should be initiated as early as possible, preferably within 48 to 72 hours with the onset of fever, because delay in antibiotic therapy carries the risk of complications and renal scarring. And the choice of antibiotic ideally depends on a lot of factors, and principally the antimicrobial sensitivity pattern in that particular area. However, the guideline panel recommends that third generation cephalosporin, so co-amoxiclav, can be used as an initial antibiotic therapy in children with suspected febrile UTI. And for adolescents with cystitis, a first generation cephalosporin or co-amoxiclav can be used as initial empirical therapy. Pooled analysis did not find any significant difference in terms of persistent bacteriuria, persistent fever after initiation, after antibiotic therapy, and recurrent UTI in next 6 months after completion of therapy between third generation cephalosporin, co-amoxiclav, or co-trimoxazole. However, there was persistence of clinical symptoms was reported when co-trimoxazole was used for treatment. So as far as route of administration is concerned, it is preferable to give oral antibiotic therapy over intravenous antibiotic therapy for treatment of acute febrile UTI, except when the infant is less than 2 months of age or the child is severely ill and unable to ingest oral antibiotics. And if an intravenous antibiotic therapy is initiated, once the child is better and the organism shows sensitivity, it may be switched over to oral therapy after 3 to 4 days. And many times it happens that patients respond clinically in terms of improvement in fever and clinical symptoms. However, when we get the culture report, the organism is resistant to the first line antibiotic. So the guideline panel suggests that initial antibiotic therapy should be changed only in patients with clinical treatment failure, regardless of the antibiotic sensitivity patterns, because there is difference in vivo and in vitro antibiotic sensitivity. And the previous guidelines suggested 10 to 14 days of antibiotic therapy, and now it is recommended 7 to 10 days of antibiotic therapy is enough in children with acute symptomatic UTI, because the studies show there is no difference in persistent fever or persistent symptom or recurrence of UTI when we use 7 to 10 days of antibiotic versus 10 to 14 days of antibiotics. And for children with cystitis, a shorter course of 3 to 7 days of antibiotics is enough. So to summarize, when a child is diagnosed with urinary tract infection for cystitis, one can very well give oral antibiotics for 3 to 7 days, in addition to supportive care with hydration, antipyretics. When we are faced with febrile UTI or pyelonephritis, if a child is young, there is suspicion of sepsis, renal uncontentedness, there's poor oral intake, then it's better to admit and start intravenous antibiotics. Otherwise, these children can be started on oral antibiotics. 90% of patients will have resolution in clinical symptoms and fever within 48 to 72 hours. If there is lack of clinical response, these patients should be promptly evaluated with an ultrasound and cultures to look, and the culture report should be reviewed for resistant uropathogens, and ultrasound for identifying any perinephric abscess, pyonephrosis, or urinary tract obstruction, etc. And after the child is better after IV antibiotics, one can switch to oral antibiotics to complete a total duration of 7 to 10 days. Now, next pertinent question is, because there is a risk of recurrence of UTI and the most common risk factor being VUR, how to follow up these children? Previous guidelines were very aggressive in terms of imaging. The 2011 guidelines recommended that any child below 1 year of age who develops first episode of UTI should undergo an ultrasound, micturating cystourethrogram, as well as DMSA scan, while children between 1 to 5 years should undergo ultrasound and DMSA scan, and if either is abnormal, MCUG should be performed. So now these tests are associated with exposure to radiation. They involve catheterization, which involves discomfort to the child. And after one episode of UTI, we know that approximately 20 to 30% children will have underlying VUR. So rest of the children might undergo that test unnecessarily. So considering the balance of evidence, a less aggressive approach seems appropriate. And most of the Western guidelines have already recommended that. Most of the guidelines recommend an ultrasound, while the UK guideline, NICE guideline recommends ultrasound only if the child is less than 6 months or recurrent or atypical UTI. Atypical UTI is defined as presence of urosepsis, poor urine flow, abdominal mass, raised creatinine, lack of clinical response, non-E. coli infection, etc. While rest of the American Academy of Pediatric guidelines recommends MCUG to be performed only in recurrent UTI, and DMSA scan is not recommended. The NICE guidelines also recommend MCUG for recurrent or atypical UTI. So are the Swiss and Italian guidelines. But one should know that if ultrasound is abnormal, then MCUG has to be performed. So the present guidelines recommend that ultrasound scan of urinary tract should be performed after the first episode of UTI in children, and it can be performed anytime during treatment or after treatment. If there is clinical treatment, clinical response is lacking, then it should be done promptly while the child is undergoing antibiotic therapy. And a micturating cystourethropography should be performed in children with one of the following: UTI caused by non-E. coli uropathogens in children less than 2 years, because it may be indicative of underlying abnormality of the urinary tract, like with reflux. Children with abnormal ultrasound scan should undergo micturating cystourethrogram, and when there is history of recurrent UTI. And the recurrent UTI has been defined as 2 episodes of UTI during childhood. And the guidelines do not recommend performing acute phase DMSA scan in children with febrile UTI, because the DMS. Sorry for the interruption. So the DMSA scan involves radiation and it may not be available everywhere. Plus, in acute space, it may show some photopenic areas due to pyelonephritis, and it has poor predictive value for diagnosis of reflux. And also, acute phase scan does not tell us whether those photopenic areas are going to convert into scarring. So, acute phase DMSA scan is not recommended, but a late phase DMSA scan, which is done 4 to 6 months from the episode of UTI, is indicated to assess kidney scarring in children with recurrent UTI or high-grade reflux. In children with low-grade reflux, a DMSA scan may not be needed. So just to summarize the algorithm, for the first episode of UTI, all children should undergo an ultrasonography. If abnormal, one should go ahead with the MCOG and DMSA scan, which should be done 4 to 6 months from the episode of UTI. If ultrasound is normal, we should maintain a clinical follow-up to see whether these children go on to develop second episode of UTI. But there are features like non-E. coli UTI in a less than 2-year-old, abnormal ultrasound, or recurrent UTI, then these children should undergo a MCOG scan. And recurrent UTI is defined as 2 episodes of febrile UTI during childhood, and the guidelines have not mentioned any time frame that these UTI within a year or so. Any 2 episodes of febrile UTI during childhood qualifies for recurrent UTI. So once the child has recurrent UTI, it is important to prevent it. Around 10 to 30% of children may have recurrence of UTI, and primary reflux and bladder bowel dysfunction are the most important risk factors. And 10 to 15% children with acute pyelonephritis may have renal scarring. So it is very important to prevent the UTI. 2011 guidelines recommended antibiotic prophylaxis in all children with primary VUR, but antibiotic prophylaxis has its shortcomings as well. There is higher risk of febrile UTI with resistant uropathogens in children who are taking antibiotic prophylaxis, and the critical outcome of renal scarring is not affected by antibiotic prophylaxis. So we have to use antibiotic prophylaxis in a rational manner. So the guidelines recommend using antibiotic prophylaxis for prevention of UTI in patients with, recommend against using antibiotic prophylaxis for prevention of UTI in patients with a normal urinary tract and absence of bladder bowel dysfunction. So in the absence of risk factors, one should rather maintain a clinical surveillance with prompt detection of UTI at the onset of symptoms and offering treatment rather than continued antibiotic prophylaxis. And antibiotic prophylaxis should be the first line of management in patients with high-grade VUR because in this population, it has been found to be helpful in preventing UTI, and these children are at high risk of developing recurrent UTI. The guideline panel suggests that antibiotic prophylaxis may be considered in preference to surveillance in patients presenting with recurrent UTI and bladder and bowel dysfunction, irrespective of presence or absence of primary VUR. I'll discuss bladder bowel dysfunction in detail in little further, but the REVO trial and also the trial from AIMS for children in recurrent UTI of antibiotic prophylaxis in children with VUR, both the trials identified that the subgroup of patients with bowel bladder dysfunction are shown to benefit with use of antibiotic prophylaxis. Although in low-grade reflux, antibiotic prophylaxis is not recommended, but in infants with recurrent febrile UTI, even with low-grade VUR, clinicians may consider using antibiotic prophylaxis. And again, there is another group of children where we give antibiotic prophylaxis even before they develop UTI, that is children with antenatal hydronephrosis. The antenatal hydronephrosis guidelines published in 2013, they recommend any newborn who has the AP diameter more than 10 millimeter should be put on antibiotic prophylaxis while awaiting evaluation. However, evidence suggests that antibiotic prophylaxis is not effective in preventing symptomatic UTI in this population, and rather it increases the risk of developing febrile UTI with resistant uropathogens. So the newer guidelines recommend against using antibiotic prophylaxis for prevention of symptomatic UTI in children with antenatally detected hydronephrosis while they are awaiting evaluation. So, and the drug of choice, the two antibiotics have been recommended in children more than 3 months, cotrimoxazole or nitrofurantoin, to be used as first line for prophylaxis. Both of them achieve good concentrations in the urinary tract, and nitrofurantoin is more effective. However, because of its gastrointestinal side effects, the discontinuation rate is high, and Ceptran, cotrimoxazole, has been used safely in most of the studies and trials of the psychoureteric reflux. And how long to give antibiotic prophylaxis? The antibiotic prophylaxis should be discontinued in children older than 2 years if they satisfy all the 3 criteria. The toilet training has been achieved, there is absence of bladder bowel dysfunction, no febrile UTI in the preceding 1 year. So we have to maintain minimal 1 year of UTI free. Studies have shown that the risk of recurrence of UTI does not increase much once you stop prophylaxis between 2 to 4 years. But if you stop prophylaxis in younger children, the risk of recurrence of UTI is high, particularly if there is bladder and bowel dysfunction. So other measures for prevention, circumcision is one of the methods which can be considered as one of the intervention for prevention of UTI in boys at high risk with high grade VUR for recurrence of UTI. And in good hands, circumcision has low complication rate, and pooled estimates show in this at-risk population, it may reduce the risk of UTI by up to 82%. And there has been interest in cranberry products to be used for prevention of UTI. Most of the data comes from the adult studies, but the guidelines recommend they can be used for prevention of UTI in children with the recurrent UTI and in those with normal urinary tract as well. And how much dose to give? A study showed that 300 ml of cranberry juice, which contains 36 milligram of proanthocyanidins, is needed for its anti-adhesive effects on the uropathogens. However, a larger dose of 72 milligram may offer better protection. However, its availability, feasibility, and use, those are costs, etc., are the considerations for prolonged use. Talking about bladder bowel dysfunction, it is a syndrome of combined bladder and bowel dysfunction in the absence of any neurological abnormality, and it is an important risk factor for UTI. As you can see in the Venn diagram on the right hand side, in children, toilet trained children not on antimicrobial prophylaxis, those with bladder bowel dysfunction, the recurrence of UTI was 35%. With combined VUR and bladder bowel dysfunction, 51%, with VUR alone 20%, and without any risk factors, 32%. And when bladder bowel dysfunction is present, it delays the natural resolution of reflux and it may lead to failure of endoscopic reflux correction. And the International Childhood Continence Society suggests urotherapy to be used as a first line therapy for bladder bowel dysfunction. So the guidelines suggest that all children, all toilet-trained children with UTI should be evaluated for bladder bowel dysfunction. You can take history of presence of bladder symptoms like increased frequency, voiding postponement, daytime incontinence, Rome 4 criteria or the Bristol stool chart can be used for assessment of constipation. A DVSS questionnaire by Farhat and Farhat can be used for objective assessment, and on follow-up, we can also document the improvement in bladder bowel dysfunction. And one can do an ultrasound to look for post-void residual urine X-ray for transverse rectal diameter. And children with refractory bladder bowel dysfunction need to undergo uroflowmetry and urodynamic study. And the guideline recommend all children with bladder bowel dysfunction should be managed with urotherapy for prevention of UTI recurrence, because the study meta-analysis has showed that the pooled prevalence of bladder bowel dysfunction in patients with UTI is very high, up to 40%, and it occurs in together with VUR in up to 50% of children and significantly increases the risk of UTI. So it is important to take measures to resolution of bladder bowel dysfunction. And first line is urotherapy, that is maintaining avoiding diarrhea, increasing fluid intake, regular voiding, double voiding, correcting the posture, maintaining good hydration, ensuring good fiber intake, and laxative like polyethylene glycol can be used. And if there are symptoms of overactive bladder, anticholinergic drugs should be used. Care should be taken to take care of constipation before starting these drugs. For dysfunctional voiding, alpha blockers may be added. For underactive bladder, clean intermittent catheterization or biofeedback therapy may be employed. And those children who are refractory of botulinum toxin, usually it is not required. One should aggressively try the first line and second line measures before reaching the third line measures. Coming on to primary vesico-ureteric reflux, it occurs in 30 to 40% children with UTI, and around 15 to 20% with antenatal hydronephrosis have reflux. Sometimes it may just be an incidental finding when you're evaluating the patient for something else. And 7 to 17% associated with end-stage kidney disease. And mostly these are children with congenital hypodysplasia. Previously, reflux was considered to be a sinister condition associated with complications like proteinuria, hypertension, and progression to end-stage renal disease. However, even with aggressive management of reflux, the rate of the contribution of reflux to end-stage kidney disease has remained stable. It has not decreased, and now we know that mostly the children with congenital hypodysplasia are the ones who would progress to renal failure. Not all the children. The acquired scarring carries little risk for progression. Overall, 1 to 2% of population is affected by VUR, but it is likely to be an underestimate. And there is also familial clustering. And in sibling screening, the prevalence has been found to 27 to 30%. And there is no single gene locus or gene associated with VUR. However, in syndromic children, one should look for concomitant anomalies of the urinary tract like ureterocele, local anomalies, vesico-ureteric junction obstruction, duplex system, etc. So previously, aggressive management of reflux was advised based on the fact that it leads to complication. And now we understand, research has shown that recurrence of symptomatic UTI is similar, whether we do surgery or use antibiotic prophylaxis. However, there is less febrile UTI in the group treated with surgery. And there's no difference in the most critical outcome, that is renal scarring, on long-term follow-up at 5 years and 10 years between surgery and antibiotic prophylaxis. And surgery doesn't prevent progression to end-stage renal disease. These are mostly the children with congenital hypodysplasia, so no measures can actually prevent them. We can simply maybe delay the end-stage renal disease. And percentage change in GFR is similar in both the groups. And open surgery versus endoscopic correction, success rate is obviously better with open surgery, but it also comes at the cost of increase. It is an invasive procedure, increased hospital stay, pain, etc. And for lower grades of reflux, endoscopic correction is an acceptable option. And bladder bowel dysfunction may lead to failure of endoscopic correction. So in light of this evidence, the primary focus during management of patients with primary VUI should be to prevent recurrence of UTI rather than management of VUR as such. So the guidelines recommend that antibiotic prophylaxis should be the first line of management in patients with high-grade VUR, and surgical reimplantation should be considered in patients with high-grade VUR who have recurrent breakthrough febrile UTI on antibiotic prophylaxis, that is 2 or more UTI. In children with high-grade VUR, surgical intervention may also be an alternative for parental hesitancy to use prolonged antibiotics. Some parents may opt for the surgical option, that is all right. And when surgical intervention is indicated, patients may be given option of endoscopic injection of bulking agent as an initial therapy with guidance from the physician about its minimally invasive nature also, but the lower success rate as compared to ureteric reimplantation, particularly in the higher grades of reflux. To summarize, when we have patient with primary VUR, low-grade VUR needs to be managed conservatively. They do not need long-term antibiotic prophylaxis unless they have bladder bowel dysfunction, while high-grade VUR, antibiotic prophylaxis should be the first line of management, and aggressive management of bladder bowel dysfunction when present. Those who have breakthrough UTI or when the parents opt for surgical correction, that may be offered. How to follow up a child with vesico-ureteric reflux? We know that high-grade VUR may lead to renal scarring, may be associated with complications like hypertension and proteinuria. So these patients and reflux nephropathy is defined as presence of photopenic areas and contour changes on the DMSA scan. So children with high-grade VUR and reflux nephropathy need periodic follow-up to detect long-term complications. The growth should be monitored, blood pressure, proteinuria, renal function should be monitored. Older children with VUR, recurrent UTI, those with concomitant bladder bowel dysfunction are at particular higher risk for reflux nephropathy, and children with congenital dysplasia are at the highest risk of long-term complications. Ultrasound is suggested to be performed periodically to monitor the kidney growth in children with persistent high-grade VUR. In young children, it can be done annually. In older children, it can be done less frequently. Repeat DMSA scan should be repeated only in children with recurrence of UTI. And we know that reflux also resolves naturally. The resolution rates are higher for lower grades of reflux, up to 72% of grade 1 reflux resolve, 61% of grade 2, 49% of grade 3, and 32% of grade 4 and 5. Presence of renal scarring, recurrent UTI, and bladder bowel dysfunction delays the resolution. And the resolution is also higher chances in the children where VUR is diagnosed during screening for antenatal hydronephrosis. However, a repeat MCUG for resolution of reflux is not required if the child is clinically asymptomatic, and even if required, it may be performed at least after 4 to 8 years because resolution of reflux takes time. And otherwise, if the patient needs surgical intervention in view of recurrent UTI, at that time MCUG may be repeated, or there is progression of the renal damage in high-grade VUR, then the MCUG may be repeated. And we know that there may be increased incidence of VUR in the siblings. So guideline panel recommends, suggests screening of siblings particularly less than 3 years of age with primary VUR with an ultrasound scan. And if the ultrasound is abnormal, they should also undergo a MCUG and DMSA scan. And older siblings of VUR children, careful history should be taken for presence of UTI. If they have a UTI, then they should be evaluated with ultrasound, MCUG, and DMSA scan. And there's no evidence to suggest that management of syndromic VUR is different from non-syndromic VUR, and additional anomalies like ureterocele, vesico-ureteric junction obstruction, etc. should be managed accordingly. And these children need long-term follow-up. So in adolescent, they should be transitioned to adult nephrology care. So to summarize, these updated guidelines are based on robust methodology, good evidence, and they are applicable for international use. And the key salient changes from the previous guidelines are a urine culture with 10^4 colony forming unit is considered significant for diagnosis of UTI in an infant if the clinical suspicion is strong. Urine leukocyte esterase and nitrite can be used as alternative screening tests to urine microscopy in children with suspected UTI. Acute pyelonephritis can be treated with oral antibiotics in a non-toxic infant for 7 to 10 days. MCUG is indicated in children with recurrent UTI, abnormal ultrasound, and in patients below 2 years of age with non-E. coli UTI. DMSA scan is indicated only in children with recurrent UTI in high-grade VUR. Acute phase DMSA is not recommended. Prophylaxis is recommended to prevent UTI in children with bladder valve dysfunction and those with high-grade VUR. And in children with VUR, antibiotic prophylaxis should be stopped if child is toilet trained, free of BBD, has not had UTI in the last 1 year. Antibiotic prophylaxis not indicated in children with normal urinary tract, and surgical intervention in high-grade VUR can be considered for parental preference over antibiotic prophylaxis or in children who are having a breakthrough febrile UTI. So thank you for patient listening, and now we can take questions again.
Any questions from the audience?
Before we take on the questions, Vanessa and Dr. Prashant, would you like to add your comments?
Very nice presentation, Swati.
Thank you.
I think it does summarize what is the sort of latest thinking. Being a part of the first recommendation and the second recommendation and the third recommendation, and it's very tough job. You cannot satisfy everybody, but I think the overall message which you have given is we should not be doing unnecessarily MCUGs and not giving too much of prophylactic antibiotics.
That is right, sir. Dr. Prashant, would you like to add on?
So I just want to ask two questions, Dr. Swati. Very good presentations. And I have one question that very frequently we see children who are older than 10, 12 years old, and they come to us with recurrent urinary tract infections. You will investigate them. You will obviously will not do invasive investigations, but when you investigate them with ultrasound, then ultrasound is normal, but still they continue to have recurrent UTIs. Now, I would like to know what will be your approach in such patients who are older children who did not had any previous history of UTIs, but they had history of recurrent episodes of UTI with delayed onset, I would say.
Yeah, most important thing we would these children should also be evaluated for bladder valve dysfunction, which is fairly common, and usually UTI at this age is more common in girls. And despite after management of bladder valve dysfunction, if they continue having UTI, we should perform a MCUG and a DMSA scan in these children as well.
Okay, so you mean to say we need to investigate them in case if the symptoms are persisting?
If yes, the UTI continue to recur and there is bladder valve dysfunction has been dealt with reasonably.
And obviously, it's very unlikely for them to have vesico-ureteric reflux. The only problem which you might find out on investigations is some sort of bladder dysfunction.
Yes, bladder dysfunction, that is a part of the bladder valve dysfunction one should evaluate in detail. And although reflux, children with vesico-ureteric reflux generally present at young age with recurrent UTI, sometimes you may find and a reflux in older age also. But bladder valve dysfunction is the most important thing one should carefully evaluate and manage. Vanessa, would you like to add?
My second question will be that in what conditions you will be more aggressive to manage these patients of UR surgically?
So I could not hear the last part of the question. There was some disturbance.
So most of the time we will try to manage these patients with UR, with conservative management, with uroprophylaxis. But are there any situations when you will be more aggressive in advising them for surgery?
So maybe when the patient has damaged kidneys and there is still time, see if the patient has already progressed to stage 4, stage 5 CKD, there is little use in correcting the reflux. But at earlier stage, if the patient has renal damage continues to have recurrent UTI, we would be more aggressive. But again, bladder wall dysfunction should be dealt with. And although duplex system, we know that the resolution of reflux may be slower. These present guidelines recommend that even in duplex system, the reflux should be managed in a similar way as we would manage reflux in non-duplex multis. Would you
Okay,
like to add?
I mean, one more condition is the child is having a single kidney, or maybe
Yes,
even
single kidney with damage,
solitary
obviously you will be
single
more
kidney with
aggressive.
VR. One has to be slightly more aggressive in
More
managing this.
aggressive managing this.
I think that's it. Thank you so much.
Yeah. Thank you, sir.
So we have one question in the chat box. If the child has been given oral antibiotics empirically and a culture turns to be positive, should the antibiotics be changed to sensitive antibiotics?
Yeah, if the
Dr.
patient,
Swati.
yeah, I had addressed this in the guideline. If the patient has responded clinically, then you need not change the antibiotics and you can continue the same antibiotics which you originally started, but you should ensure that the symptoms have resolved.
And another question.
नहीं यहीं पे पढ़ो क्यों
Please elaborate on antenatal hydronephrosis or pelvic ileal system dilatation. What is anything specific to these conditions?
Okay, this is a topic in itself, and antenatal hydronephrosis. So what we follow is in the second and third trimester, AP diameter more than 4 millimeter in the second trimester, more than 7 millimeter in the third trimester, and after birth in the postnatal period, more than 10 millimeter is considered significant. And then you also need to see in the ultrasound, other than AP diameter, whether there is the ureter is dilated, whether there is parenchymal thinning, whether there is caliceal dilatation, and determine the risk of significant underlying pathology. And then accordingly, we evaluate these children. Where AP diameter remains below 10 millimeter, we generally follow these patients with ultrasound for resolution, because up to 80% of antenatal hydronephrosis will resolve spontaneously, and this is transient hydronephrosis. Only on those babies who continue to have persistent hydronephrosis, or if the ureter is dilated or bladder outflow obstruction is suspected, then you should evaluate and manage accordingly.
Okay, next question, role of alkazol in UTI.
Alkazol can be used for symptomatic relief, particularly in the older children who present with, younger children usually do not present with burning, micturition or urinary tract specific symptoms. So alkazol is simply a symptomatic treatment. By changing the pH of the urine, it gives symptomatic relief. So briefly, it can be used in older children. And
I think the last question is role of doing kidney function tests in first episode of UTI.
Role of doing kidney function tests in first episode of UTI. If you are using antibiotics like amikacin, then on the 4th or 5th day of antibiotic, one should do. And otherwise, in a stable child whom you are managing on OPD basis, unless there are ultrasound is abnormal, when you're suspecting on the basis of ultrasound the bladder outlet obstruction or something, or high, and children those who have high grade VOS should undergo. Otherwise, maybe the children who are admitted, when it is okay to do kidney functions and electrolytes once, or those who are on getting nephrotoxic drugs. There is another question that nitrofurantoin is very poorly tolerated, even cotrimoxazole. So nitrofurantoin, agreed, children have nausea and children do not tolerate it very well. So we use cotrimoxazole, is easily available in my clinical experience. Usually it is well tolerated also. And we do not routinely do G6PD deficiency before starting nitrofurantoin. Vinay sir, do you do G6PD test for G6PD?
No. The dose is too low.
Yes.
Yeah.
So hardly we do not encounter. Most of the problems with nitrofurantoin are only nausea, vomiting. So most of the patients are not able to continue it.
Dr. Swati, may I ask one question?
Yes, sir. Please.
You had a very good presentation on the new recommendation. Now, suppose we have a child with UTI 2 episodes or 1 episode. How do you go about the bladder bowel dysfunction in each child with UTI, or there certain group only you should consider to treat them for BBD? Or you
Sir,
think ki treatment of UTI is sufficient enough and I should forget it?
Sir, all toilet trained children, even with first episode of UTI, should be evaluated for bladder bowel dysfunction because it is far more common than reflux. So, and it is based on simple history taking and evaluating the bladder and bowel habits of the child. You can evaluate, and simple measures by increasing fluid intake, scheduled toilet visits, double voiding, frequent voiding, increasing fiber in the diet. With simple measures, you may be able to prevent episode of UTI. So in all toilet trained children, we should carefully evaluate for bladder bowel dysfunction.
So this is an important part of treatment
Important part, yes, sir. It is
even
important.
in toilet and also even in toilet
Yes.
trained children.
Yeah,
And when you right, and when you send that child for this thing now, he should go for the invasive procedures with just 2 episodes. I'm just asking you.
Yes, sir.
Episodes are there now. What should we should send first? Started BBD also, and now you should plan for imaging studies. MCU,
Yes.
you will tell.
MCU
Right.
for recurrent UTI. And
Right. And the DMSA will come when? What with the absolute?
later. DMSA in children who have recurrent UTI and those who have high grade VUR. By high grade VUR, we mean grade 3, grade 4, and grade 5. Grade 1 and 2 are classified as low grade VUR.
Okay,
And DMSA should be performed 4 to 6 months from the episode of UTI because we are more interested in looking at renal scarring from the UTI or reflux.
Okay, thank you.
One last question, Dr. Swati. What is the antibiotic of choice in infants less than 2 months of age?
We can use for prophylaxis in younger infants, we can either use cefalexin or amoxicillin.
Yes.
And after 3 months, we can use cotrimoxazole or nitrofurantoin.
6 बजे 6 से 9
All right. So we've come to the end of today's BLK Teleped seminar. I congratulate Dr. Swati for conducting the session so well and giving us so much information on a very common topic. And my heartfelt gratitude to our chairpersons, Dr. Vinay K Agarwal sir and Dr. Prashant Jain sir. Thank you so much for giving us your valuable time. And a big thanks to all the participants for a patient listening. I hope you have a very lovely day. With that, I, Dr. Ritika Goyal, pediatric pulmonologist at BLK Hospital, I sign off. A very good afternoon and a very good day to all of you. Thank you.
Thank you, everyone. Thank you.
Thank you.